Hey, welcome to part 4 of the Go to Physio knee series. Now today we're going to talk about how to use small knee bends, but to make them specific to a step-by-step treatment plan that's going to be helping you get a rock solid treatment plan in place. So with your rehab program, up here we're going to have change of direction. So what we want to do with our low level rehab exercises, especially small knee bends, is we want to start the process of that graded exposure program so that we build a rock solid foundation. So by the time the athlete's gone to change direction, the knee, the gastro, the hamstring, the glute, they've all been in these length tension relationships already. So then the next step is just the next little bit of load. So we're not jumping from 0 to 100 and risking flare-ups or risking our patients' symptoms actually coming back or actually making them worse. Okay, so this is how we do it. We use the low level exercises today to start the process to get back to the high level change of direction. I hope you enjoy the content. So a very important thing to consider with your rehab for the knee joint is that the knee joint needs to move in 3 planes of motion. So I remember when I was first out of university, even when I was on placement in some NHS hospitals, I remember being taught by my educators, knee needs to stay over the second toe. Well, unfortunately, in real life, that doesn't happen, okay? Because when I twist and when I change direction, you can see where my knee is actually now, okay? Or if I have to go this way, my knee now is over my little toe, okay? So if I have to cut this way, if I have to go this way, again, my knee will travel in and out past that second toe. So just take that into consideration, that maybe cueing an athlete or a patient to keep the knee over the second toe may not be the best use of your time. And I'll never forget one of the worst or most stubborn knee pain cases that I've ever seen with a professional athlete who had, greater than 12 years playing professional sport. He played international level and quite a lot going on inside the knee, and it was only when he came to the club and I had to get him out of actually letting his knee stay over the second toe, because every exercise he was doing, he was so focused because it had been drilled into him, and it was only when we actually allowed his knee to go inside his foot and outside his foot that we were able to make a change in that pain experience. Okay, so just keep it into consideration about, challenging your belief system about, okay, does that knee stay over that second toe in everyday life? And in sport, when things are happening with thoughtless, fearless movement, unfortunately it doesn't. So the exercise that I would like to introduce you to, that a lot of people will use for knee pain, is something like the single leg squat, okay? So Pete, if you just come over here towards me a touch, and then just pop back a tiny little bit, and then all I'll get the patient to do is, Pete, I just want you to do an exercise for me where you're gonna stand on your left leg, and then I just want you to reach your right foot forward for me, okay? So you're just gonna reach it, whoops, I'm drunk, and then back again, okay? So you're just gonna reach it forward and then back again. So that kind of single leg reach, I'm not gonna cue the athlete too much because I wanna see the strategy that he's using, okay? So if you just do that for me, Pete. That's it, I'm back again, perfect. Now, keep going for me, Pete. Now, as Pete does that, I'm looking at where his knee is going naturally, okay? Now, if I feel I wanna decrease the perceived threat of that knee, maybe if it was an MCL, for instance, and I wanted to lower that knee and cause a little bit of valgus, okay? Because I know that, okay, he's injured his MCL, for instance, in the past few weeks, but I want to put a little bit of load through that MCL now so that it can adapt, but most importantly, so the nervous system can have confidence when that knee actually goes in there in real life, because it will go in there in real life at some stage. So what I would ask Pete to do then is, Pete, instead of reaching towards an imaginary 12 o'clock, is I want you to reach out to about 2 o'clock, okay? So I just want you to reach out to 2 o'clock and then come back again, okay? Make sure it's pain-free, make sure you're comfortable. Perfect, and you can see what happens there. That's just, I want to put a little bit of change in that pain experience, okay? So just keep it into consideration. Looking straight ahead, and I want you to reach your right foot to 3 o'clock. Okay, so now that's going to really put a valgus force on that knee, okay? So what we might do with a knee rehabilitation session for whoops, I'm drunk, and then back again, okay? A few weeks, even if the athlete's in a brace, we might be doing, okay, Pete, back to 12 o'clock. We might, or if I have to change direction, okay? It comes out of the knee brace and we want to start to put a bit of load through that MCL again. We might start with 1 o'clock, and then we might get to 2 o'clock, and then we're going to go to 3 o'clock. Good. So you can see the different reactions that happen. Now, we could flip that on the reverse if we were dealing with an LCL. Pete, I want you to reach that right foot over towards 10 o'clock. Okay, so you're just going to reach out to 2 o'clock and then come back again. Okay, make sure it's pain-free, make sure you're comfortable on the knee. Okay, and we're going to get lengthen different tissues. Okay, so through the knee, then at the back, force on that knee. Okay, so what different tissues around the knee, and give the brain options. Okay, so we want to show the brain that it's safe to use the knee in as many different ways as possible, so that we're not reliant on one specific way. Okay, because if I just use my knee and I'm doing all my rehab over my second toe, is that really going to transfer when I have to go like this, or if I have to change direction? Okay, so that's an exercise that it's worth looking at. And if we really want to put some stress through the knee then at the back end of the rehab, and we want to start working towards a change of direction, then we're going to talk about that in the return to play section on this knee month. But one exercise that we can do early doors, okay, or kind of mid rehab before we get back into the return to play is, Pete, I want you to keep your left foot there, and I want your right foot to go to 4 and 5 o'clock. Okay, so as that foot goes to 4 and 5 o'clock, you can see now we're going to get a frontal plane force, but we're also going to get a transverse plane force. Okay, so we're going to start to really load those tissues now in all planes. So we've got a sagittal plane because the knee is flexing. We're going to get a valgus, and we're going to get an internal rotation of that femur. Okay, so we're really going to stress those tissues in the sagittal, the frontal, and the transverse. So let's just see that, Pete. Good, perfect. Good stuff. And just doing that for somebody with, you know, post ACL, LCL, you know, PCL even, just getting the knee to twist around those motions again, it can be very, very reassuring and give the athlete a lot of confidence. Okay, so that position there, when we go straight to 4 or 5 o'clock, we're going to revisit that again in the return to play, because that's one of the first progressions we're going to do before we get that athlete to build up integrated exposure towards changing direction. Okay, because that's going to be a key mechanical resemblance to when that athlete has to change direction. Okay, so just keep that in mind. Okay, it's the same when the athlete is cutting. If he has got problems pushing off, then I might want to, you know, do a little bit here where he's got good intention to floor as I reach this foot that way. Okay, so just start to stimulate some thought here now into your rehab programs. Okay, if that person's got medial knee pain, okay, for instance, and the person comes into me on the first session, now I want them to get their knee moving again, and I want them to get their hip and their ankle all working together, and I want to give them confidence and reassurance. But if the knee is painful here at the moment, then maybe that might not necessarily be the best exercise to give him on the first session. But what I can do is I can get Pete to reach, okay, Pete, I want you to reach your right foot to 10 o'clock, and I want you to do 3 sets of 6 of those when you get home. Okay, so try that for me. Any pain with that, Pete? So I can get the athlete using the knee again and moving, but we're not actually having any pain experience, okay? Whereas if we've done some maybe hands-on treatment, and we've combined a rehab, and we've reassured the ability to generate torque in different muscles, in the second session then, when we retest, okay, maybe this then may be a little bit less painful because maybe particular tissues aren't being used or stressed as much, or maybe the rehab has started to maybe modulate the pain experience, okay, and modulate the messengers coming up to the brain, which is then obviously altering that combination that's resulted in this pain experience. Okay, so just mixing up and giving the knee, the ankle, the hip options can have massive implications on the pain experience. Again, we don't quite know the exact mechanisms by how all this works, but we know that it does help. Okay, that it can be very, very non-specific, the exercises that we give. But my outlook on this is we'll give the system as many options as possible. We'll reassure specific movements that maybe the system isn't good at generating torque or having good intent. So the second, third session then, we may want to come across these movements here. And don't forget, we may not necessarily just be doing this movement. We might be working with something on the hip, the ankle, whatever else we find in our objective assessment and the patient's story. Okay, so that's your rehabilitation techniques to consider for the knee joint. Just consider not necessarily cueing knee over the second toe, but giving the knee as many options and opportunity to work with the ankle and the hip also. So I hope you enjoyed that content today. As I said, it's just a simple way to get you to the next step so that we always know where we're going, so that the next step is the next ultimate logical step, or we're not skipping any steps. Now, if you've any issues with that, always go back to find the true cause of the problem, because again, the knee symptoms are usually just the actual symptom and not the true cause. So if you're getting any pain with any of those movements, ask yourself what's in the injury history that we've covered in previous parts of this series to what's driving the knee pain experience in the first place. If you found this content useful, head over to thegotophysio.com. I've got plenty more tips over there for you also. So with that said, something to think about. I'll see you in the next episode where we start to really build up and ramp up the rehab and the higher level rehab progressions. See you next time.